Good afternoon, all. Now I request the Master of the Ceremony, Dr. Mudalakshmi Madam, to take over.
Good afternoon, everyone. I welcome you all for the national webinar titled Fluoride as a risk factor for preeclampsia. Now I welcome Dr. Sai Deepika for invocation sub. I welcome Sai Deepika.
श्रीधर मोर हरि करुणा वारी श्रीधर मोर हरि करुणा वारी श्रीधरी श्रीधरी कमलदल लोचना कमलदल लोचना पतित पाप विमोचना कमलदल लोचना पतित पाप विमोचना नारायण नामं नारायण नामं देवाति देवाति श्रीधर मोर हरि करुणा वारी श्रीधरी रामनाथ दीनबन्धो रामनाथ दीनबन्धु क्षमीकरोति करुणा सिन्धु रामसङ्गीता नामं रामसङ्गीता नामं देवाति देवाति श्रीधर मोर हरि करुणा वारी श्रीधरी श्रीधरी
Thank you, Dr. Sai Deepika. Now I welcome our Professor and HOD, Vice Principal Dr. K. N. Shashidhar sir, to give the welcome speech. Over to you, sir.
A very good afternoon to one and all. Myself, Dr. Shashidhar. I am the professor and head of the Department of Biochemistry and Vice Principal, Sri Devaraja's Medical College. Ours is the constituent of Sri Devaraja's Academy of Higher Education and Research, a deemed to be university. Under the Department of Biochemistry, we have an established fluorosis research and referral lab, which has been recognized as Center of Excellence by our academy, that's Sri Devaraja's Academy of Higher Education and Research. The very purpose of our establishment of FRRL is to fulfill the societal commitment of our institution by performing fluoride analysis in water samples in and around the campus as well as the geographical areas which are affected with fluorosis. This conjunction supports the district authorities in fluorosis mitigation. The FRRL, I will be abbreviating the Fluorosis Research and Referral Lab as FRRL, also provides health education and the webinar series, which aids to bridge the gap of fluorosis research by bringing all the like-minded people who are into the fluorosis research by highlighting on the potential areas of fluoride research with recent trends. Fluoride, as we all know, it's a monoatomic anion which acts as a double-edged sword, wherein the deficiency or excess can have deleterious health effects. The deficiency of fluoride, once it was thought, had been implicated with addition of fluoride with the toothpaste and various other food that we used to consume. However, it has been observed that of late, the concentration of the fluoride in the drinking water itself has crossed beyond the acceptable limit. The other end of the spectrum, which comprises of the dental, skeletal, and non-skeletal fluorosis, needs to be addressed as of today. So, the studies that has been conducted till date on the fluorosis has concentrated more on the dental fluorosis. Very few studies have been observed with respect to the non-skeletal fluorosis, that is with respect to the systemic effects of the fluorosis. Whether it may be starting from cerebrovascular accidents to various other diseases, including the pregnancy and preeclamptic toxemia. A lot of research has been done even in our institution, and many publications has been brought out with respect to the adverse events of the fluoride exposure, toxic levels of fluoride exposure. The excess of fluoride exerts its toxic effects by inducing oxidative stress, hormonal disruptions, and neurotoxicity. At the cellular levels, the various studies have confirmed that it inhibits the enzymes through competition with magnesium by inhibiting the enolase enzyme, inhibits the phosphoryl transferase reaction, inhibits ATP by multifactorial mechanism. It acts as an enzyme disruptor in a variety of tissues with both inhibitory and stimulatory effects. It disrupts transmembrane signaling, G protein cascades, and integrative networks. So the lot of research that has been done at the cellular level has observed and documented that it's not only the major organs that are affected, even at the cellular level, various metabolic pathways, including the genetic level also, there are a lot of mutations that have been happening with respect to the fluoride exposure. The current knowledge on preeclampsia indicates that it is a complex multi-system disease. The placental ischemia may lead to small for gestation age babies. It is plausible that the fluoride might be able to affect the development of preeclampsia. At present, on this basis, it is more likely that than not that fluoride is a risk factor for the development of preeclampsia. Madam has done a lot of research. Lajya Devi Goyal Madam has done a lot of research with respect to this. So this has made us request Madam to be our resource person. Thank you, Madam, for accepting our invitation. We are very grateful for extending your acceptance to be our resource person today. As we all know that Kolar is in the topographical belt of fluorosis endemic areas in India. The possibility of fluorosis affecting pregnancy has been explored here in Fluorosis Research and Referral Laboratory under the aegis of Department of Biochemistry, Sri Devaraja's Medical College, with in-house studies. It is indeed a proud moment at the findings demonstrated here contributed to the new knowledge generated in plausibility of excess fluoride evincing preeclampsia. Fluorosis and its linked disorders cannot be covered in one exhausting session, and hence the webinar series every month on month that we are conducting from the Department of Biochemistry under Fluorosis Research and Referral Lab. This webinar focuses on fluoride as a risk factor for preeclampsia and hopefully serve as a future reference for potential translational research. I welcome today's resource person, a distinguished luminary, as I mentioned, in the field of OBG, Dr. Lajya Devi Goyal ma'am. Madam is the professor and head OBG, AIIMS Bathinda. Madam is the life member of AIIMS, FOXY, Association of Gynecology, Oncologist of India, Association of Plastic Surgeon of India. Madam has got vast experience in trainings at Gynecology, Oncology at Tata Memorial Hospital, Mumbai and Kidwai, Memorial Cancer Center, Bangalore, endoscopic training at Sunrise Institute of Medical Sciences, Kochi. Madam has got more than 50 publications in international and national journals and book chapters. Madam is the Associate Dean Research and Chairperson Research Cell, Member Ethical Committee, AIIMS Bathinda. Madam is the Chairperson of Ethical Committee, Central University of Punjab. Madam is the Editorial Board Member of ARC Journal of Gynecology and Obstetrics, Journal of Gynecology and OBG, World Journal of Reproductive Medicine. Madam, with your support, we expect our FRRL to take a new turn from today onwards, so that we can reach new heights with respect to extending our service, not only with respect to the skeletal, extraskeletal, and as well as community also we are having. And we are also having plan to extend this to floriculture, horticulture, agriculture, bovine, and various other fields also. We expect your support and inputs regarding this, ma'am. I welcome you, ma'am. I also welcome our management, our president, secretary, Vice President, our Honorable Pro-Chancellor, Chancellor, as well as Vice Chancellor, Registrar, Dean, Faculty of Medicine, Dean, Allied Health and Basic Science, Medical Superintendent, my department faculty, and various other participants who have participated for today's webinar. I welcome one and all. I welcome Madam once again. Thank you, ma'am. Thank you for accepting our invitation. Please, you can take over.
Over to you, ma'am.
Yeah, at the outset, I'm very thankful to Dr. Shashidharan for giving me this opportunity to be with you all today. And it was actually very nice introduction given by Dr. Shashidharan, and he has a great knowledge about the fluoride, which is a relatively rare topic, but it is endemic in almost all the regions of India and in so many regions in the world also. So I'm very happy to learn that you people are doing so many studies on fluoride, and you are extending into the other fields also, like bovine and health and agriculture. So I would like to share my screen, and then we'll see whether. So very good afternoon to one and all present over here. So without wasting much of a time, I'm going to start the presentation. The topic given to me was fluoride as a risk factor for the preeclampsia. It is a very novel topic for me because it is usually we talk about preeclampsia, but relationship with fluoride I'm talking for the first time. I have done a study on fluoride levels in pregnant ladies in way back in 2015 to 2016, and we studied around 500 women with preeclampsia after 20 weeks of pregnancy. We actually studied the urinary sample of those patients, and to my surprise, 100% of the women we studied, they had the urinary symptom, urinary levels of preeclampsia more than the permissible limits given by the WHO. So all the women in Punjab was affected with preeclampsia, and then we graded the levels of fluoride into low, medium, and high, depending upon the level of secretion in the urinary in the urine of fluoride. So 80% of the women who were affected with high levels of fluoride were anemic, and out of those, around 6 to 7% had major malformation, and pregnancy was terminated because of the malformation. So this was a new finding as far as the fluoride was concerned from my study, which was published in 2020. So preeclampsia is caused in 20% of the anemic women. So I was thinking at that time, because 80% women are anemic, they may also be develop preeclampsia. So fluoride somehow may be associated to preeclampsia indirectly because it causes anemia also. So this was there in my mind. But after this topic was allotted to me, so when I searched the literature, though there are not many studies on preeclampsia and fluoride, but there was a study from Karnataka itself. They have found that it could act as a biomarker for the preeclampsia in future. So let's study how the preeclampsia and the fluoride levels are related. But initially, I'll be talking about the preeclampsia classification, risk factors, pathophysiology, and then finally I'll be discussing with the with association with the fluorosis. So as we all know, there is a classification of hypertensive disorders in the pregnancy. It is given by the American College of Obstetrics and Gynecologist. And according to this classification, the hypertensive disorders are classified into chronic hypertension with pregnancy, which is hypertension which is pre-existing before the pregnancy or which is already there before 20 weeks of pregnancy. Then the second component comes gestational hypertension, which is a mild hypertension without proteinuria. Preeclampsia, that means there is a hypertension, means BP is more than 140/90 associated with proteinuria or some multi-system disorder. And when any patients of gestational hypertension or preeclampsia develops seizure during pregnancy, then it goes under the classification of eclampsia. And any patient with chronic hypertension can develop superimposed preeclampsia or eclampsia. So these are various disorders of hypertension in the pregnancy. These are classified like that. So coming specifically to preeclampsia, it is defined as a multi-system disorder characterized by hypertension of at least 140/90 millimeter of mercury, recorded on two separate occasions at 4 hours apart, in the presence of at least 300 milligram of protein in 24-hour collection of urine, rising after 20 weeks of gestation in a previously normotensive women, and resolve completely by 12 weeks postpartum. So from this definition, we can say that preeclampsia is a retrospective diagnosis, because if the BP doesn't come back to normal after 3 months of postpartum, it is not classified under preeclampsia. It goes in the definition of chronic hypertension, because many patients, they may not be reporting to us before 20 weeks of gestation, so that we can document them that the hypertension is pre-existing. And as far as the definition of preeclampsia is concerned, 20 weeks of gestation is cut-off limit to document to classify as preeclampsia. So preeclampsia is not antepartum diagnosis; it is a postnatal diagnosis after 3 months of pregnancy. Then preeclampsia, we know it is a gestational hypertension with proteinuria. And as we know that preeclampsia and eclampsia is the second leading cause of maternal mortality globally as well as in India. The first being obstetrical hemorrhage, and this also hypertensive disorders also causes around 14% of the maternal mortality in India, and it is also cause of a great uh, perinatal mortality in India as well as in the other parts of the world. So now preeclampsia affects around 5 to 7% of all pregnant women, and it is responsible for over 70,000 maternal deaths and 5 lakhs fetal deaths worldwide every year. Most frequent cause of fetal death is iatrogenic prematurity and preterm delivery, intrauterine growth retardation, perinatal death, and placental abruption. Now, just briefly, I want to tell you that normal blood pressure changes during the pregnancy. In the first trimester, there is a slight decrease in the blood pressure, and it reaches at the lowest level during 20 weeks of pregnancy, and finally it returns to the pre-pregnancy level during the third trimester. So in each trimester, there is a variation in the blood pressure levels during the pregnancy. So this should be kept in mind. Now, the preeclampsia is divided into mild and severe. What is mild preeclampsia is that when the gestational age is more than 20 weeks, if any patient presents with the sustained high blood pressure of more than 140/90 with proteinuria of 300 milligram per 24 hour or more, it is called mild preeclampsia. And severe preeclampsia is when the BP is more than 140/110 with proteinuria more than around 5 grams in 24 hours, and with any symptoms like headache, pain epigastric, and visual changes. Visual changes means usually patient has blurring of the vision, and usually these patient presents with oliguria. Oliguria is also another sign of severe preeclampsia. So if any patient is having high BP of 160/110 with any of these symptoms, even uh, without so much of a proteinuria, then it can be classified in the category of severe preeclampsia. So eclampsia is addition of convulsion in a woman with preeclampsia, and it occurs in around 0.5 to 4% of the deliveries, and 20% of the patient who have eclamptic seizure during the antepartum period, that is before the labor, and 50% may develop eclampsia during the labor, and 25% can have postpartum seizures also. So it is a preeclampsia plus seizure plus convulsion, and sometimes patient is found in coma. And if any patient of high BP during pregnancy is found in coma, we have not witnessed the convulsions, then also it is labeled as eclampsia only. Now there is another category that is called HELP syndrome. HELP means, H means hemolysis, EL means elevated liver enzyme, and LP means low platelet count. So any patient with hemolysis, elevated liver enzyme, and low platelet count is categorized as HELP syndrome. 4 to 12% of the patient with severe preeclampsia and eclampsia may develop HELP syndrome. So this is also a constellation of finding the pathophysiology of preeclampsia is responsible for the development of the HELP syndrome. So now coming to the etiology may be classified into genetic factors, immunological factors, endocrine factors, nutritional factors, and infectious factors. Now coming to the one by one, if we discuss the genetics, there is a usually in preeclamptic patients there is a genetic predisposition, and only those patients who are having family history, usually they have the family history, those patients who are having preeclampsia. And preeclampsia is more common in blacks and Asians compared to the Western countries, and it is genetic factor is also supported by on the fact that pregnancy caused by the ovum donation, they have more chances of having preeclampsia compared to the pregnancy by the same by the natural cycle. Then second is age and parity. Preeclampsia is more common in teenager age, and it extremes of the age in the teenager age, like in the age less than 18 years or age more than 35 years. And if there is a long interval between the pregnancy and the pregnancy, that is 10 years between the two pregnancies, and it is of course more common in primary gravidas. And partner factor is also responsible. Sometimes if there is a change in partner in those pregnancies, there may be development of preeclampsia. There, those patients who are having limited sperm exposure, they are having more chances of preeclampsia. Pregnancy which is caused by donor insemination may have more chances of preeclampsia, and preeclampsia is common in the partners fathered who have already fathered an eclectic pregnancy. Then the list is not over. There are so many pregnancy factors which are responsible for the development of the preeclampsia. That is multiple pregnancy. As we all know, that placenta is the main culprit in development of preeclampsia. So in multiple pregnancy, the placental volume is very high. So that may be the factor. And in HMOL also, because the placental volume is high, so these two conditions, molar pregnancy and multiple pregnancy, preeclampsia develops even before 20 weeks of pregnancy. And in hydrops fetalis also, because the placental volume is very high, there are also high chances of developing preeclampsia. And there is one fetal chromosomal anomaly, that is trisomy 13, which is associated with the preeclampsia. And other underlying medical diseases which contribute to the preeclampsia are chronic hypertension, diabetes mellitus, renal diseases, cardiovascular diseases, hyperthyroidism, and metabolic syndrome. So all these patients with any of these underlying disease, they are more prone to have preeclampsia. The other factors include obesity, especially when the BMI is more than 35, or if the patient is having psychological stress, or patient is a smoker, or there is a previous history of preeclampsia. So these are the known etiologies. Now there are some new recent etiological factors which are thought to be very important in the development of preeclampsia are hyperhomocystinemia. It is considered as a marker of preeclampsia. Antiphospholipid antibodies, those patients who are having high level of antiphospholipid antibodies, they are more prone to have preeclampsia. Then fluoride is the recent one which is thought to be a biomarker. And then those patients who are having immunological factors like thrombophilia, those are also considered to be a causative reason for the preeclampsia. Now coming to the pathophysiology of preeclampsia, how the preeclampsia develops. In normal pregnancy, what happens? There is a invasion of the cytotrophoblast cell of fetal origin into the maternal spiral arteries. So what this invasion will lead to, they will transform them to from small caliber to a large caliber capacitance vessels, because they will destroy the muscularis mucosa of the spiral arterioles, and this and convert into a tortuous channel, so that more it is capable of providing very good placental perfusion to the fetus for the fetal growth. So this is a non-pregnant spiral artery. This is a normal pregnancy tortuous vessels when there is a good invasion of the cytotrophoblast cells into the spiral artery. But what happens in preeclampsia? The invasion is poor and the spiral artery will not dilate. So there is a less blood supply which goes to the fetus. So this is more clear in this diagram. When the in preeclampsia, what happens? The cytotrophoblast fail to invade the endothelial properly. So see, you can see in this diagram, the cytotrophoblast are not invading the spiral vessels properly. So invasion of the spiral vessel is shallow and they remain small caliber compared to in normal pregnancy, when the caliber of the vessels becomes very high. And because of this small caliber, the blood supply to the placenta is reduced, so placenta undergoes ischemia. So when this type of spiral arteries, this is an unmodified artery, this is a modified artery by the trophoblast. So tortuosity is lost after the invasion of the trophoblast, and it will create a high flow low resistance zone in the vessels. This will result in loss of spirality and replacement of smooth muscles of endothelium with the trophoblast. So it will become a very tortuous vessel. Now, because of impaired or inadequate trophoblast into the spiral artery retain their narrow, tortuous, and high resistant character, which leads to reduced blood supply to the placenta, and this results in placental hypoperfusion. And as a result, there is this result of hypoperfusion as a compensatory mechanism. Blood pressure becomes high in the maternal circulation, because ultimately the blood has to reach to the fetus to give it a nutrition. So this is another theory of the development of preeclampsia. When there is an inadequate trophoblast invasion and defective remodeling of spicle, placental ischemia and inflammation happens. This will lead to systemic inflammation, apoptosis of the cells, oxidative stress, and release of placental factors. And all these things, four factor, oxidative stress, apoptosis, inflammation, release of placental factor, will lead to endothelial dysfunction in entire body of the patient. So this causes maternal syndrome. So what is maternal syndrome? Is that preeclampsia, the pathophysiology starts in early pregnancy because of the reduced placental perfusion and abnormal implantation. And in the later stage, in the second half of pregnancy, because of this reduced perfusion, there is a development of hypertension, there is a development of proteinuria and endothelial dysfunction, and the placenta secretes some toxic elements, and that goes into the maternal circulation. So let's see what are the elements which are secreted which goes into the maternal circulation. So into the maternal circulation, there are angiogenic factors and anti-angiogenic factors which are secreted by the placenta. So angiogenic factors are vascular endothelial growth factor, including placental growth factor and transforming growth factor beta, and anti-angiogenic factors like soluble MFS like FMS like tyrosine kinase 1 and soluble endoglin. These are increased, and the vascular endothelial growth factor and transforming growth factors are decreased in preeclampsia. So what will this lead to? This will lead to imbalance between the vasodilators and vasoconstrictors. So which are the vasodilator? Vasodilators are the nitrous oxide and PGI2, and this is produced by the syncytial tuboblast and the endothelium. And vasoconstrictors are the angiotensin 2, which is secreted by the placenta, endothelial 1, which is secreted by endothelial, and thromboxane 2. So usually there are more vasodilator compared to compared to the vasoconstrictor, but in preeclampsia the opposite happens. There are less vasodilator and more vasoconstrictor, which leads to high resistance flow and development of high BP and related complications. Now, what are the inflammatory mediators? Inflammatory mediators are PGI2 and thromboxane A2. PGI2 is decreased and thromboxane A2 is increased. So this will lead to vasoconstriction, platelet aggregation, increased vasopressure response, and increased uterine activity. So all these are the main culprits in the pathophysiology of preeclampsia. So with release of these many inflammatory mediators and vasoconstrictors and imbalance between the vasodilators, so what happens to each system in the body? In cardiovascular system, there is a generalized vasospasm, there is increased peripheral resistance. Both vasospasm and increased resistance are responsible for high BP as well as capillary injury, and this leads to reduced central venous and pulmonary pressure. In renal system, there is a proteinuria because of the widespread endothelial injury. There is a decrease in glomerular filtration rate, and there is a decreased urate secretions. That's why the uric acid levels are very high, and this is considered as a biomarker for the preeclampsia. In liver, what happens? There is a periportal necrosis and subcapsular hematoma because of the because of the coagulation deformities also. And then in hematological systems, there is a platelet activation and depletion. This will lead to low platelet count. There is a coagulopathy. There is a decreased plasma volume and increased blood viscosity. And in central nervous system, because of the intense vasospasm of the brain vessels, there is a development of cerebral edema, and sometimes the blood vessel ruptures and leads to cerebral hemorrhage. Now, what happens with this? As every organ in the body is affected by the preeclampsia, so what are the effects of those on those organ? In uteroplacental, there is a development of, as the blood is not going to the fetus, so there is intrauterine growth retardation, and when the blood is very high, then this can BP is very high, then this can lead to abruptio placenta. In hematological system, this may manifest in the form of epistasis, DIC-like features, and hemoconcentration. In central nervous system, there is a development of cerebral edema and leading to seizures. In heart, there is a subendothelial hemorrhage, focal necrosis, and cardiomyopathy and heart failure. In lungs, these patients may present to you first time with the pulmonary edema or hemorrhagic bronchopneumonia. In kidney, there is a oliguria and glomerular endotheliosis. Liver, of course, there may be, the patient may present with pain epigastrium. It is because of the ischemia and peripartal necrosis, and ultimately these patients can have HELP syndrome. So now, which investigations you will like? Mainly, I have not gone into the details. Usually we get urine examination for proteinuria, kidney function test, liver function test, coagulation profile, and ultrasound for the fetal well-being. Now, in treatment of the hypertension, treatment of preeclampsia is divided into two components. That is treatment of the hypertension and prevention of the seizure. So antihypertensive drugs usually used in pregnancy are methyl dopa, hydrazine, labetalol. All of them are equally good in controlling the hypertension, but ultimate treatment of the preeclampsia is delivery. Now, in seizure prophylaxis, usually it is required in severe preeclampsia because we don't want any patient to develop eclampsia. So magnesium sulfate is a very good drug of choice, which can be initiated and before the onset of labor, and can be given till 24 hours postpartum. Uh, it is a very good drug in controlling as a seizure prophylaxis as well as for the treatment of preeclampsia. I am not going into very much detail of this drug, but ultimate the definite treatment is delivery. And for delivery, we can categorize the patient into three categories. In those patients who where with the treatment the symptoms have subsided, or in the second category when there is a partial control, and third when there is a no control and BP is increase persistently high. So in first category, we can wait till the spontaneous onset of labor, and in second category, when the symptoms are not getting controlled, if the patient is 37 weeks already, we can terminate, and if the patient is less than 37 weeks, we can do expectant management at least till 34 weeks. And if the patient, the BP is persistently high or increasing, then we have to terminate irrespective of the uh, period of gestation. Now, this is about the preeclampsia, and there is a exhaustive pathophysiology of preeclampsia. Until now, there is no single marker which we can say is responsible for the development of preeclampsia. However, every day some or other new things or new markers are added. Now, today our topic of discussion is fluoride, association of fluoride with the play. So, just I'll have few slides to give you overview of fluoride. Fluoride is a naturally occurring chemical found in the groundwater in India. An estimated 62 million people, 2 million children in 17 states are affected with endemic fluorosis in India. The upper limit of optimal fluoride level in drinking water is 0.5 ppm or zero point 0.5 milligram per liter. This is given by WHO. And as we all know, fluoride affects various organs like skeletal system, dentist, and it crosses the placenta and cause several pregnancy associated complications. So if we see the map of India, there are 10 top Indian states which include Rajasthan, Telangana, Karnataka, Andhra Pradesh. These are the 10 states which are having very fluorosis is very high, and it is crippling in these 10 states. And now we all know what are the source of fluorosis. As we know, it is water, groundwater from the wells, tube wells, and hand pumps, maybe rock salt and masalas and chaat masalas. And there are some fluorinated, fluorinated toothpaste, which dental product which have fluorine. So these are the source of fluorosis. And as sir has already said, the fluoride is a double-edged sword. So we all know that small amount of fluoride is required. It is essential in the body for the mineralization of bones and formation of dental enamel. So the requirement is less than 1 milligram of fluoride per liter of water. That is essential. But however, if it goes more than 1 milligram per liter of water, it can lead to fluorosis. And fluorosis, we know that there is extensive literature available on the dental enamel damage and on the skeletal damage. Then what are the effects and target group? The fluoride can affect any age group. In children, it causes dental and skeletal fluorosis. In adult, it causes skeletal fluorosis. And in pregnant women, it can lead to pregnancy complications like severe preeclampsia, intrauterine growth retardation, mental retardation, and the baby extra. So actually, it affects every category: children, women, men, and pregnant lady. And what are the effects? The type of fluorosis mainly till now which is discussed is dental fluorosis and skeletal fluorosis. And dental fluorosis, there may be volumes of literature which are present, but today's topic is risk in pregnant women. So as we all know, the fluoride passes from the mother to the fetus through placenta. And in mother, it can cause congestive heart failure. It can cause hypothyroidism, anemia, preeclampsia, and maternal myopathy and oxidative stress. In the children, it can lead to the children who are born with low intelligent quotient. It can lead to premature babies. It can lead to even stillbirth and congenitally malformed babies. So, what is the association of preeclampsia with fluorosis? There is not much of a literature available. However, when I was going through the literature, I found this article that serum fluoride level as a biomarker in the development of preeclampsia. This is a case control study done in the Karnataka by Chingel and al. So what they found that serum fluoride level was significantly higher in preeclamptic cases, and they found that fluoride is an added risk factor for preeclampsia, and maternal serum fluoride level more than 1.8 milligram per liter can be considered as a diagnostic biomarker for predicting the preeclampsia and related pregnancy complications. So this is the hypothesis they have given based on their study results. But this particular study was analyzed by this paper, and this paper shows that they have given that it could be considered as a biomarker. The question follows whether the associated between raised fluoride level and preeclampsia is causal one. So ultimately, after the analysis, they found that on this basis, it is more likely that than not the fluoride is a risk factor for development of preeclampsia. However, as we all know, pathophysiology of preeclampsia is complex and it will become clearer over the time, and more research is required. So, to find the association between fluoride and preeclampsia, they used the Bradford Hill criteria. According to this criteria, that if we have to see the association between two variables, that variable A and B are associated is not a proof that change in A is directly responsible for change in B or vice versa. So there are 9 aspects of the association, that is strength, consistency, temporality, plausibility, biological gradients, coherence, and experiment analogy. So out of those, plausibility and coherence was uh, these two criteria was taken. Two of the 9 criteria was taken to establish a causal relation between the fluoride exposure and preeclampsia. So what they found that coherence was, they found that it was good correlation, because when it was examined with respect to low birth weight, which is a known fact for natural history and biology of fluorosis and preeclampsia, they found it is a good criteria which matches the association between the fluoride exposure and preeclampsia. So when they study the second, that is plausibility, it was examined by whether or not there is a known effect of fluoride that might affect the proposed pathophysiology, and what result they found that it was considered plausible that fluoride may be able to affect the development of the disease. However, the pathophysiology of preeclampsia is complex and will become clearer with the time only. So what are the possible mechanisms whereby the fluoride may affect the pathophysiology of preeclampsia? Some of the mechanism Dr. Shashidhar has already said. So there are few I'm going to discuss over here. The fluoride causes impaired cytotrophoblast transformation. As we have already studied, that cytotrophoblast transformation is the main thing which is responsible for the development of preeclampsia. So it causes impaired cytotrophoblastic transformation from the proliferative subtype to the invasive subtype. So invasive subtype, when the invasive subtype is poor, it will not invade the vessels and may lead to the development of preeclampsia. Second mechanism is oxidative stress, which is produced by fluoride. It is a risk factor for atherosclerosis of the uterine and spiral arteries. So atherosclerosis of the uterine and spiral artery will make them narrow, which is responsible for the high resistance flow, which is a main cause in the preeclampsia. Then the third mechanism may be that fluoride impairs the stromal transformation of uterine endometrium to prepare for the implantation. Then the fluoride can lead to overexpression of hypoxia inducible factors like HIF1 alpha and HIF2 alpha. And fifth one is it leads to reduced expression of heme oxygenation 1, which is responsible for the main blood supply in the preeclampsia. Now, the another possible mechanism may be there is inhibition of natural killer cell response, because natural killer cell response is a immune response which develops in the mother as the fetus is considered as a foreign antigen. So there is a usually the mother will not react because these natural killer cell response is there. So fluoride seems to inhibit the natural killer response. So fetus will act as a foreign body and it will induce the immune changes, and immunological factors are responsible for the development of preeclampsia. Then there is an increased expression of anti-angiogenic protein like FMS, like tyrosine kinase 1 and soluble endoglin. So these are also caused by the fluoride. So this is one of the mechanism. And there is a reduced expression of interleukin 10. This is also an autoimmune agent which is responsible for the development of preeclampsia. And also, as we studied in the pathophysiology, there is increased angiotensin 2 sensitivity, including hypersensitivity of angiotensin 2 types receptor 1 through forming a complex with the bradykinin receptor 2. And lastly, there is increased sympathetic nervous system activity with the fluoride. So I have found very few studies on this, and which were supporting the fluoride as a marker for the preeclampsia, or there is some association with the hypertension. So first study was by Emini et al. They found a positive correlation between the fluoride concentration in groundwater resource and prevalence of hypertension in male and female. The another study was from Karnataka, which we have already discussed, and they found significantly high level of fluoride in the preeclamptic patient compared to the control group, and it was 1.8 compared to 0.8 respectively. And third study was by MacArthur and all in USA. They found that prevalence of preeclampsia was higher in those most fluorinated region of USA compared to the least fluorinated region of USA. So only this much literature I could found on the association between hypertension and preeclampsia and fluoride. So now this much about the association. Then if there is a fluorosis, how will we manage? We all know that we must avoid the rock salt, chaat masala and tea, because it is high level are found in those things. But we should consume good calcium rich foods, and we should get the food which are antioxidant rich. And this is how that endemic area we must promote these type of foods, and of course the water and the fluorinated toothpaste and all should be avoided in these regions. And high calcium is most important in detoxing the fluoride level. So now coming to the end, the take-home message is that preeclampsia is a multi-system disorder with complex pathophysiology, and it is the second leading cause of maternal mortality worldwide. And of course, the etiology of preeclampsia is multifactorial, and serum fluoride may affect the pathophysiology of preeclampsia, and serum fluoride level may be used as a biomarker in the preeclampsia. The last, thank you very much for patient listening.
Thank you, ma'am. Thank you for the insightful and informative session on the fluoride as a risk factor for preeclampsia. Now the session is open for discussion. Any questions? I request the participants to please ask, or you can put forth in the chat box as well.
Thank you, ma'am. Now I request Dr. Susan, ma'am, to propose vote of thanks. Over to you, ma'am.
I, Dr. Susanna T.Y., Associate Professor, Joint Organizing Secretary for today's webinar. On behalf of the Department of Biochemistry, I extend my heartfelt thanks to our speaker for the day, Dr. Lajya Devi Goyal, Professor and Head, Department of OBG, All India Institute of Medical Science, Bathinda, Punjab. Thank you, madam, for sparing your time from your busiest schedule to grace the occasion. And we had an opportunity to hear your thoughts and work on fluoride in preeclampsia. This, I hope, will surely encourage our fellow colleagues in the future research work. I take this opportunity to thank our patrons, late Sri R.L. Jalapa, founder, president, SDUET, Sri G.H. Nagaraj, president, SDUET, and honorable chancellor of SDUHER, Sri Rajendra, vice president, SDUET, Sri Hanmant Raju, KG, secretary, SDUET, Honorable Pro-Chancellor Dr. C.V. Raghuveer, Honorable Vice-Chancellor Dr. Pradeep Kumar Ji, our Principal Dr. Sri Ramalu, Medical Superintendent Dr. Sheila, Vice Principal and Professor and Head Department of Biochemistry Dr. Sashidhar K.N., Deputy Medical Superintendent Dr. Dinesh K., for being the catalyst that stimulate us to do our best. I need to mention my deepest sense of appreciation to Dr. Sai Deepika, Research Associate and Organizing Secretary of today's webinar. I also extend my thanks to all the staff members of the Department of Biochemistry for their participation and cooperation. Last but not the least, a big thanks to each one of the participants of today's webinar. We value your presence with us today. Finally, I would also like to thank the people who worked behind the screen to make this event happen, our technical team, department clerk and housekeeping staff. I once again thank one and all. Thank you.
I request all the participants to turn on the cameras so that you can take a screenshot. Dear participants, please turn on the screen. Okay, you are taking the screenshot. Thank you one and all for your participation. And thank you, Dr. Lajya Devi Goyal, madam, for your informative session. Thank you everyone. The feedback form is posted in the chat box, as well as it will be sent through to the email as also. The e-certificate shall be generated upon the submission of the feedback form. Thank you.